Hi, I'm Juan Frias, an endocrinologist at the University of California, San Diego. I was asked by IDOC to discuss some recent data, focusing on data presented at the American Diabetes Association meetings recently held in San Diego on advances in insulin therapy. As a general theme over the past several years, what's been happening with insulin therapies is development of either insulins or devices or co-formulations with insulin to more closely mimic normal physiology or the healthy beta cell. So with basal insulins, this means insulins with longer and flatter profiles and less variability. And with bolus insulin, it generally means quicker acting insulins that start and act faster and actually act for a shorter period of time, so more closely mimicking normal beta cell secretion of insulin after a meal. So what I'd like to discuss is several presentations that were at the American Diabetes Association meeting looking at a very interesting co-formulation of rapid-acting insulin, either insulin analogs or regular insulin, with hyaluronidase. And what this does actually is accelerates the absorption of insulin, of the fast-acting insulin, and by accelerating the absorption of insulin leads to a reduction in postprandial glucose. So the first abstract that I'll cover was a poster presentation which actually reviewed 6 studies that were done previously. These were short-term studies. 3 of them were in healthy volunteers. They were glucose clamp studies looking at the pharmacokinetics and glucodynamics of insulin lispro in combination with hyaluronidase versus insulin lispro alone. And then there were 2 meal tolerance test studies, one in patients with type 1 diabetes and one in patients with type 2 diabetes, looking at the glucodynamics, the pharmacodynamics of this combination, of this co-formulation versus insulin lispro. And across these 6 studies, what was consistently found was, from a pharmacokinetic perspective, is quicker onset and higher peaks of insulin with the combination or this co-formulation, and later on in the profile, so after 2 hours, lower insulin concentrations compared to insulin lispro alone. And in looking at what this translated to from a glucodynamic perspective, it was greater insulin action or lower glucose early on during the postprandial period or early on during the clamp, and then less insulin action later on after 2 to 4 hours after administration of the insulin. So again, this mimicking the normal beta cell more closely with more rapid uptake of insulin and more rapid or a shorter duration of insulin action subsequent to its administration. There was another study that was presented actually as an oral presentation by Dr. Satish Garg at the Barbara Davis Center in Denver. And this looked at patients with type 1 diabetes who were well controlled with a hemoglobin A1C, a baseline of less than 7. There were approximately 45 subjects who were treated with either a co-formulation of regular insulin with hyaluronidase or insulin lispro. It was a 12-week crossover study. And the primary objective, or the primary endpoint of this study, was glucose excursions around 3 meals at the end of each 12-week treatment period. And what was found was that these glucose excursions were actually similar with the regular human insulin co-formulated with hyaluronidase compared with insulin lispro. There was maintenance of hemoglobin A1C, as would be expected, as these patients had very good A1C and a mean of 6.9 at baseline. And there was no increase, or no difference, I should say, in hypoglycemia or in adverse events. So from a clinical perspective, what this shows is by adding hyaluronidase to regular human insulin, you get a glucodynamic effect, or the glucose lowering in glucose excursion, similar to that seen with a rapid-acting insulin, in this case insulin lispro. And lastly, there was a late-breaking poster, which was the first study done in looking at this co-formulation of rapid-acting insulin with hyaluronidase in insulin pump patients. And this was a 72-hour study in patients with type 1 diabetes that assessed insulin aspart co-formulated with hyaluronidase versus insulin aspart alone. And consistent with previous findings in the studies I just described and other studies that have been done by Halozyme, there was a significant reduction in postprandial glucose or postprandial glucose excursions with the addition of hyaluronidase to the insulin aspart. And also, and I think very clinically important, there was less glycemic variability during the 72 hours with regards to insulin absorption. And this is something that is frequently an issue for patients with type 1 diabetes who are on pump therapy. And this being that they might have a different insulin response to insulin during different days of generally a 3-day wear of an infusion set. And what was shown in this study is that there was less variability in insulin absorption when hyaluronidase was used or co-formulated with aspart compared to aspart alone. And this could potentially have important clinical implications for patients with type 1 diabetes in the future. I think also important in this study, and it's been shown in the past as well, is the skin biopsies were performed at the insulin infusion sites, and there were no differences seen in the acute inflammatory response or the response to having the infusion set in either arm. And this will obviously be studied in longer-term studies as well, but based on these data and previous data that have been presented by Halozyme, there does not appear to be an issue locally at the skin infusion site with the use of the hyaluronidase. So I think this is very interesting, though there certainly are formulations of insulin that are being developed that act more quickly, and again, the importance being mimicking the normal beta cell to improve postprandial glucose control and lessen the potential for late postprandial hypoglycemia. But here we see that co-formulating the insulin with hyaluronidase, which accelerates the absorption of the insulin, can have an effect that may be similar to that seen with just a different insulin entity. This will potentially be important and needs to be looked at in longer-term clinical trials, both from an efficacy perspective and also a safety perspective, but should be important in controlling postprandial glucose, potentially in reducing hypoglycemia, and maybe even in reducing weight gain with insulin therapy. So thank you very much, and for more information on this topic as well as other topics presented at the American Diabetes Association, please log in to idoc.org.